All right, here we go. Okay, so this is my evidence-based quality improvement project that I did for my BSN, my senior research class. It is on reducing the occurrence of ventilator-associated pneumonia in critically ill patients. So ventilator-associated pneumonia is a gram-negative necrotizing pneumonia that was first discovered in the 1950s. It was first thought to be caused by, obviously, contaminated ventilator and respiratory equipment. And then as early as the 1980s, the infections were occurring in up to 28% of mechanically ventilated patients. And of course, that is patients that have been ventilated for at least 48 hours. So the importance of addressing this is ventilator-associated pneumonia is an avoidable complication, and it increases the patient suffering, leads to increased complications and increased mortality rates. It also coincides with quality standards for improving patient-centered care. They're also tracked by healthcare oversight commissions, and to stay in compliance, you have to report those numbers and be below a certain threshold. And then lowering the rates helps to reduce lengths of ICU stay, reduces hospital expenses, and leads to lower usage of antibiotics. And then reducing infection rates helps reduce staff workload as well. Some of the articles that I pulled up for it, this one kind of focuses on pandemic times. It was from 2022. And it just kind of talked about the symptoms of COVID and ventilator-associated pneumonia were so similar that it was hard to diagnose. And a lot of times patients were already on broad-spectrum antibiotics and kind of, focused on like the overuse of antibiotics. So that was a really important point. For my next article, this one kind of focused on care bundles. They did a research on 38 articles were analyzed, looking at care bundles and how they were incorporated in the hospital and which hospitals were actually doing the care bundles appropriately. And they found that only 9 out of the 38 were actually doing them appropriately. So obviously that's something that needed to be worked on, and that's kind of what my project focused on, is the hospitals that aren't following the packets or the care packages. Ventilator-associated pneumonia in adults. So this was just kind of a narrative review. Said that VAP, ventilator-associated pneumonia, affects between 50 and 40% of patients that have been on mechanical ventilation for 2 or more days. The average North America average for infection rates are 2.5 cases per 1,000 ventilator days. I believe that Piedmont has a little bit worse than the 2.5, but I could not actually find the literature for it, but I feel like I saw it somewhere recently, so I can't back that up with literature. And then lastly, the last one talks about, again, it's diagnosis, management, and prevention. A lot of delayed diagnoses were done just because of limitation in diagnostics tools. Talked about antibiotic therapy. 30 to 50% of empirical antibiotic therapies do not adequately cover causative pathogens for ventilator-associated pneumonia. Antibiotic resistance is a big thing. Overuse and misuse of antibiotics has led to multiple drug-resistant organisms that have become increasingly difficult to treat. And then need for meaningful prevention strategies. Critical gaps in compliance and protocol usage are cited as reasons for improvement. Again, that's kind of what I focused on for my project. And then this is just understanding the process. This covered a patient that we had that was on a ventilator. They had been extubated. Over the course of a few days, they started going downhill again, requiring high flow oxygen, then the BiPAP, and then wound up having to be put back on mechanical ventilation again due to ventilator-associated pneumonia from their first intubation, and it just covers all the different people and staff and equipment and everything that was involved. This was just a fishbone diagram we had to do early in the class. So my SMART goal was to reduce occurrence of ventilator-associated pneumonia using visual VAP bundle checkoff signs placed on the door of mechanically ventilated patient rooms. For that, it would, obviously be a chart like we have on a lot of patient rooms, and it would have slots for the different interventions that you have to do throughout the day, and it would have times and dates and where you would sign it for check off, and it would be in an area that's visually accessible to the disciplinary teams during rounding and whatnot. So I won't go over everything for the SMART goal, but basically just to reduce ventilator-associated pneumonia. And I said my timeline that would be in the first 6 months, we'd be able to see like a 5% decrease, hopefully. So the Institute of Healthcare and Improvement, their ventilator bundle that is really kind of what we follow here at Piedmont, and not every hospital follows the same bundles, but I think that they should have one that just goes across the board that at least everybody's at least meeting that minimum, but that's not the case. So elevating the head of the bed 30 to 45 degrees, that's important for aspiration. Sedation vacations for mechanically ventilated patients. The sooner you can get them off the ventilator, the better, so you can assess them to see if they're ready to be extubated. Peptic ulcer and deep vein thrombosis prophylactics. Not really too much about ventilator-associated pneumonia, but I guess if they got an infection, it would compromise their immune system, so that could, cause additional issues. And then daily oral care. We do it every 4 hours here. I know it says daily oral care in the literature, but we do it every 4 hours here, so I think that should definitely be the standard. Team members that would be included in this, obviously the nurse, they're the ones that's going to be performing all these different protocols. Respiratory therapist, really their only job is the ventilator and positioning the ET tube correctly, because we do all the other care, like oral care and everything. Patient care techs will need to know the correct positioning for the patients, make sure they're at the correct 30 to 45 degrees. Unit educator would have to educate the nurses and respiratory therapists, everybody on the unit, about the new policies. And of course, infectious disease, that would be who was in charge of kind of tracking and monitoring it to see if they were being implemented correctly, and if not, then they would provide additional follow-up education and discipline. And that's kind of it. That's got my references here.
Awesome.
That's it.
Awesome. Good job.
Hey, I'm done. Thank you.
You're welcome.